So good morning, everyone. Thank you all for joining us today. And thank you for coming to our annual Kentucky REC annual conference. My name is Brent McCune. I'm the managing director at the Kentucky Regional Extension Center, and we're excited to be here in person today. I will also say we have a square up here, so you'll see us kind of stay around the podium because we are live streaming this as well. So we're excited to have those virtual attendants join us as also via the Hoove app. So we really do appreciate everyone coming and joining us. And Jared, okay, perfect. So I'm not sure if everyone knows what the REC is, the Kentucky Regional Extension Center is, and what we do, but to kind of give you a little bit of history, we were founded in 2010 by a grant from the Center of Medicare and Medicaid Services. And it was also some funding from the Office of National Coordinator. And we were charged to go out and work with providers and hospitals around the implementation of electronic health records, making sure that they use those in a meaningful way where they can attest to Medicare and Medicaid. So that's really was our beginning focus at the Kentucky Regional Extension Center. Over the years, we've really transformed. We've written some grants in-house. We've partnered with public health. We've actually created fee-for-service models that will provide support to those rural, underserved areas. That's our primary focus. So although we are associated with UK Healthcare, our goal is to be a trusted advisor, a strategic partner to healthcare organizations, making sure we can provide resources that you may not have available in those communities. When we look at our different services at the REC, we have, these are just, I'll talk about our fee-for-service models, but we have privacy and security. So that's really making sure your clinic or your hospital stays protected so you don't have a breach. We'll come in and do risk analysis from that perspective. We have patient-centered medical home and patient-centered specialty practices. A lot of our FQHCs have that recognition. So that's always good to look at and see if you want to get recognized as a patient-centered medical home. We have value-based payment support, and we also have quality payment program. Those are some of the Medicare programs. We hope to avoid payment penalty from that perspective and get you where you can get a bonus. Also, quality improvement support. That's a big thing right now. We hear Medicare, Medicaid, all the MCOs, all the payers, they want to improve the quality, right? So I think it's important that, we look at quality improvement support and what we can do to improve the quality and better care and better outcomes for those patients. And really, that's looking at your data, looking at your workflows, looking at how you document within your EHR to really identify and see, how do you create better care and better outcomes? So that's where we get with quality improvement support. We have telehealth services. Telehealth has really changed since the pandemic. It's, during the pandemic, it was like a rush to everyone implement telehealth. And now we've kind of backed off that where we can take a different approach and say, do we have the right technology in place to provide telehealth services and protect that patient and have a secure connection. From a hospital standpoint, we have promoting interoperability. We have our HIPAA security, and project management services, along with hospital quality. So some of the same services in the hospital sector, just a little bit different approach with our physician services. We have a lot of grants. I won't get into those today, but we have a lot of different grants that are exciting. And, we have a lot of people in this room that are part of those grants as well. Today, we have a great agenda. We have a lot of great speakers here. We have, we're talking about like social determinants of health. It's something that Medicare and Medicaid is really pushing. CDC is pushing us to look at social determinants of health and what those drivers are. How can we provide better care for that population? We have navigating social determinants of health with our health information exchange. So we're excited to have Andrew come in and talk about how they're helping social determinants of health and managing those patients from the state government perspective. We're talking about cost and quality. health equity, poverty, rural resilience. So we really have a really full agenda. We also have Story Musgrave. I'm pretty excited about that. He's an astronaut. He's got, I'll read you his bio, but he's been in space like 6 times, flown on 5 different space shuttles. So pretty impressive. Also, for everyone that has the app on their phone, we're using the Whova app today. So if you don't have that, there's a QR code on your table. You can go download it. We have bonus content out there. We created this content, recordings, just so we didn't have to go into a 2-day event. This allows us to get you material that we feel would be beneficial and that you can watch on your own time. That is available for 90 days starting now. So we definitely ask you to go out, watch that. You can see that, you know, we're talking about our Paul Coverdell grant. There's some additional social determinants of health. Talking about the Prepare tool, information blocking, which is a big deal right now to the Office of the National Coordinator, making sure you're not blocking patient information. So, so that information is out there free. You can download Whova on your phone, or you can get to it on your computer as well. It's a little bit more difficult to get to on your computer, but go ahead and download that. Also, I'd like to say thank you to our sponsors and exhibitors. Let's get to that slide. We appreciate you all visiting them. You never know what they have to offer. So go talk to our exhibitors, see if they have certain things you can offer within your healthcare organization. All of these sponsors, they help us, offset costs with food. So we're happy to have them participate there. I don't know if all of my staff, if they're up here yet, but I want to say thank you for that group. And are they around here? Doesn't look like it. Looks like they're still downstairs, other than we have some in the back. But my staff, that's really what makes the Regional Extension Center. That's what makes, they're the smart ones. I will go on and say, they do the quality improvement, the privacy and security. They set up this event. So they really are those subject matter experts that are out in your all's communities, providing support, that technical assistance. And so I want to thank them as well. Also, throughout the day today, we have something a little different than we've done in the past. We have some different client and organizational awards. These awards are organizations or people that have participated in some of our service lines, or they've been a part of some of our grants, and they've contributed in some significant way. And so those are going to be sprinkled throughout the day as well. So we're glad to have those participants in here today to kind of talk about what they've done. So we'll read off those as we move through the morning and afternoon. And I guess that's all I have, except let's just go ahead and start with awards. So let's first start with the Colorectal Cancer Crusader Award. And can I have Martha Lewis come up? Is Martha here yet? Hello. Thank you, Martha. So Martha's with Pennyroyal Healthcare Services. Pennyroyal Healthcare Services is headquartered in Princeton, Kentucky, and became an FQHC in 2013. They have participated over the past several years in a colorectal cancer screening grant and improving colorectal cancer screening rates. They have implemented several PDSAs, plan, do, study cycles, and hosted wonderful community events that have led to improvement of CRC screening rates all across their clinic locations. This clinic's commitment from their CEO and quality improvement coordinator and providers makes their work a true effort, a team effort. Congratulations to Pennyroyal and their Colorectal Crusader Award. So thank you. And here you go. And we're going to take pictures back there as well, but we'll do that at the break. So thank you. We're going to do 2 more awards. And we have our Diabetes Prevention Pioneer Award. Do we have Dr. Jane Strader here? Hello. So this award's going to King's Daughter Medical Center. King's Daughter Medical Center is a hospital based in Ashland, Kentucky, with additional locations in many other counties in Kentucky and Ohio. They are currently working with two of their providers, Dr. Strader and Shayna Bennett, APRN, for their population of focus of the Prediabetes Learning Collaborative. These two providers currently have over 1,700 patients and maintain the goal of improving health outcomes of their patients with prediabetes by referring them to the National Diabetes Prevention Program. They have made strong strides and improvements with all of their measures, surpassing all of their goals in just the first 6 months of the project. This clinic's commitment to their provider champion and improved workflow is driving force in their success. Congratulations to King's Daughter Medical Center for their Diabetes Prevention Pioneer Award. Thank you. Thank you. Thank you. All right. And our next award, I'm a little slow on the clicker here. Our next award is the Blood Pressure Buster Award. And do we have Dr. Doffett here? And Benita? I know we have Benita. Come on up, Benita. Benita Neese. So the blood pressure Buster Award goes to North Fork Community Health Center. They are part of the University of Kentucky. They participated in the Hypertension Learning Collaborative over the past year. Their focus has been to improve hypertension in their population of focus by utilizing CARE SMB program while implementing workflows that improve rates in statin therapy and hypertension. They have been successful in achieving and exceeding their goals throughout the program, which is a huge accomplishment of itself. But did I just skip something? But they were also able to make these improvements during a very hard time for Eastern Kentucky with the devastating floods that impacted their patients and staff. This clinic's strong desire for their community of patients and their health outcomes is a driving force in their success. Congratulations to North Fork Valley. Thank you. Thank you. And I mentioned the CARE SMBP program. If you want to know anything about the CARE SMBP program, I'm going to point over to our Department for Public Health group, and Natalie Littlefield, she runs that program, and it's an excellent program to be a part of. So, all right. So let's jump into our first presentation, and we're going to be talking about cost and quality and talking about strategies for providing safe and efficient care. So I'm going to go ahead and introduce Vance Drakeford and Jessica Elliott. They are part of our REC staff. They're health IT quality advisors, and they are the experts.
Thank you all so much. It is fantastic. As we're getting kind of set up here and all mic'd up, it is fantastic to get to see all of your faces, some repeat faces to previous events and some brand new faces. That's really exciting to see. And thank you to everybody who is joining us virtually on the Whova platform today. As Brent said, my name is Jessica Elliott. I'm the Quality and Value Team Lead here at the Kentucky Regional Extension Center, and I'm also a Quality Improvement Advisor. And today I'm joined by my fellow colleague, Vance Drakeford. And so what we are here to talk with you about today, everybody's favorite subject, right? Controlling cost measures, optimizing efficiency. And we understand that it's a very, it's I think easier for us in healthcare to wrap our minds around a quality improvement, right? We can see the direct results from that patient in front of us who has lowered their A1C values. And I think it's easier for us to connect to. Cost is a little bit mysterious. It's a little bit frustrating, and it's quite honestly, sometimes really overwhelming. How do you begin to chip away at this, this beast, this juggernaut? And so what our goal is for today, and I feel like I've lost the clicker, would help. What our goal is for today is to start just to kind of understand and level set what is cost? How does that impact the care that we deliver? How should it impact the care we deliver? And then looking at and trying to break down, try to demystify some of these cost measures that we're being scored and evaluated on, and to come up with some strategies for how to really move that needle to make those meaningful improvements, right? Not just changing for the sake of change, but truly changing to transform patients' lives, because that's why we're here in healthcare, ultimately at the end of the day. So everything that we do really needs to be within that purview and stay within that lens. And so as I was, doing research and trying to conceptualize how we were going to talk about this today, one of the things that really, came into my mind is everybody knows the state that we're in here in healthcare, right? We've all seen diagrams very similar to this. We know that, annually we are spending about just under $4 trillion, each year on healthcare costs. We as Americans, we are paying that into the system. And so to me, that next logical question then becomes, not necessarily me from that healthcare perspective, because I know all the different moving parts and pieces that go into that $4 trillion, but I thought it was interesting for me to reframe it and think about myself as a consumer of healthcare. What am I actually paying for in my copays, in my deductibles? What am I getting out of that chunk of that $4 trillion, right? Well, when I started to do the research, I'm finding here in the United States, we have the highest incident rates of avoidable deaths in the world compared to our other developed nations. You can see the disparity, and the gap is continuing to widen year by year by year. What else? And this to me was incredibly shocking, that here in the United States, our infant mortality rate is at 336 deaths per 100,000. The next closest country is Germany with 195 avoidable deaths per 100,000. That is unacceptable to me. Completely. Actually, I skipped ahead. There we go. There's that one. That is completely unacceptable, right? That's what we're paying for. We are also paying for increased infant mortality, right? So out of about 1,000 live births, we are seeing an incredibly higher rate than any other nation. This right here, this teal line is us. That is the US compared to our other developed nations. Similar countries, similar gross domestic products. This is what we're paying for. And to me, this is incredibly shocking and was very upsetting. If you are a pregnant citizen here within the United States, you are 2.5 times more likely to die during childbirth. That is what we're paying for. And that's not acceptable, is it? Right? As a mother, as a female, that is not an acceptable number to have in the United States with what we're paying for. We have greater incidence. Nearly a third of US citizens over the age of 18 have more than one chronic condition. So they're either going to have asthma, COPD, diabetes, cancer, depression, anxiety, or heart disease. Nearly a third of our country has more than one of those, right? So we are sicker than our peers. We are sicker than the rest of our citizens of this global economy. So now the conversation then becomes to what's feeding into this, and then how do we start trying to close that gap, right? Vance?
Clicker. Good morning. So as Jessica was talking about, what are we paying for? Let's kind of look at who is paying this cost, who is driving those healthcare costs here in our country. So we found this study in the National Library of Medicine, which I find really surprising, that the top 1% of the patient population accounts for nearly 22% of the total healthcare cost in our country. So 1% of all the patients is almost a quarter of all the healthcare costs today. And then the bottom 50% of the population accounts for just under 3% of our total cost. And that 1%, the average cost is about $110,000 per patient. And then that bottom 50% is around $276 per patient. So it's a huge, range in differences. And just that 1% of the patients drive that cost. So with that 1% of the patient population, what are they having that's causing this? This is probably not surprising to you all in this room, but it's chronic diseases. And so you can see here on this chart that the total direct cost for chronic diseases here in the States is at 1.1 trillion as of 2016. So that includes your top thing is your cardiovascular conditions, followed by diabetes, and then you have Alzheimer's, then followed by arthritis and back pain, and then cancer, and then the other conditions. But all of those conditions, those chronic diseases, are costing for that total direct cost of 1.1 trillion. Now, when you think about indirect cost added onto this, that's such things as reduced productivity because of these diseases and lost wages. That total cost goes from 1.1 trillion to almost $3.8 trillion. That is nearly 20% of the US GDP, which is about 1/5 of our total US economy. So it's pretty staggering. So what services are we using that's causing these costs and driving these costs, and what settings? So probably the biggest proponent is with hospital. 33% of that is hospital care, followed by physician and clinical services, and then prescription and retail drugs. Those are the major components that are causing the different settings and services that are causing those costs. So who's paying for it? So there's different sources of funds that it's coming from. The major contributor is, of course, private health insurance, then followed by Medicare and Medicaid, and then private insurance. So those are your major source of funds that are paying for these costs. And so the bottom line really is an increased spending. For more than 50%, what is causing that is service price and then intensity. So intensity is just talking about the number of times and frequencies and staff interventions that it takes to provide patient care, those kind of things. That is counting for greater than 50% of increased spending. So in understanding things like this, it's really going to help you as you prepare for different policies and your organizational workflows and processes to understand those different conditions and the ways that these things affect cost to really help prepare for it in the future.
Alrighty, so I'm going to talk with you a little bit about the response, particularly our payer response to the situation, the circumstances that we find ourselves in here in the United States. And one of the primary strategies that has been leveraged is really about decreasing utilization, right? And there's, this as a strategy, it does work, but it also, you have to think about the context in this. So, this decrease of utilization is looking at, reducing unnecessary testing, looking at evidence-based practice, all of these different techniques. But one thing that has been, I think, in the forefront for several years now is decreasing length of stay. That if decreasing your length of stay, you're going to lower your cost. You're going to have cost savings because patients aren't in the hospital for as long. But the research actually indicates that that isn't the case. So what's happening is that while we're doing an excellent job in healthcare of decreasing the length of stay, we are actually not reducing the items and services that are happening in that admission. We're actually, in a shorter amount of time, we are truncating the amount of time, and we're packing in even more testing and services and all of those procedures in that inpatient stay. And therefore, when you actually look at the net gains, we are actually creating more and more expense. We haven't taken out any of those high utilization pieces in that length of stay. Granted, you are able to have more turnover and throughput with that reduced length of stay, but ultimately we're not seeing those cost reductions that strategy right now is employing. And we're going to talk about why that is here in just a little bit. One of the other strategies has been reducing the overall cost of care, right? How much it costs to deliver services. And so private and public payers have come up with different strategies over the last 20, 25 years. In the late 80s, 90s, and up until the early 2000s, we saw the implementation of MCOs, right? Managed care organizations. And those have had some limited success. Ultimately, at the end of the day, they weren't meeting patients' expectations around their care, and they weren't really seeing ultimately the reason why they were designed to have the volume of savings that they initially anticipated. So we're starting to see those kind of transition out. And then we're seeing more of a focus on bundled payments of care. So looking at a particular procedure, a particular disease state, and payers saying, for your broken leg, I'm going to pay you $200 for all of the care that goes into fixing that patient's broken leg. And that's going to include any type of orthopedics. It's going to include physical therapy, any kind of labs, radiology, all of those things. We're giving, we know that doesn't cost $200, but just as an example, we're going to give you $200 per patient. And if you are under that $200, you get to keep those savings. If you're over that $200, then you have to eat the costs, right? That's what that bundling looks like. And then as a next step to that are accountable care organizations. And that's what we've seen really in the last few years start to really take hold. This is going to be more of a population-based management of your patients. It's going to look at either a physical geographical region of patients that are going to be a part of an ACO entity. It's going to look at perhaps a disease state, so a particular kind of condition, but it's going to be a more of a system-based where you can look at all the different aspects of your patient care, both that inpatient and outpatient, and you have that control over that event, that experience, and you can help then manage those costs. And that's really the direction in which this is going. And we see this through legislation. We see this through acts of Congress. We've seen this with the Affordable Care Act. We've seen this with the macro legislation that formed the Quality Payment Program for CMS. You can see all of the different models that CMS tests on their innovation website. They are creating new models with basically employing these different strategies all the time. And it's becoming and shifting into that population whole health management system. And really what's happened is that payers have said, we no longer want to be on the hook for $4 trillion each year. In order to drive the needle, we are shifting that responsibility over to clinicians, healthcare systems, and ultimately to the public healthcare consumer, right? To be able to start taking ownership of how much services that are being utilized, the overall cost, having some skin in the game by having financial risk on the table, and improving that quality care, having those good outcomes, putting that ownership into clinicians and onto the patients. And that's really those strategies with that value-based care. It's moving the risk off of that private payer and assuming that and taking that on our side of the seesaw, so to speak. So when we talk about value and what that means, CMS's definition of value is the sum total of outcomes partnered with the patient's perception of those outcomes and compared to the overall cost of care. And so when we're delving into and preparing ourselves for that value-based care world that we find ourselves standing on the precipice of, the thinking, the logic behind creating these value-based systems is that as you are experimenting and you're creating stronger and stronger patient outcomes, you're having improvements in that quality sphere, you're probably going to still have high costs, right? Because you're in that transition phase, but you're having high costs and are justified by those high outcomes. Then through further and further optimization, you're able to still maintain those quality outcomes while you're strategically reducing your expenses. Your successful systems, truly successful systems that have transitioned to value-based care, they have found a way to be able to offset the loss of revenue from a healthier patient population through patient volume, right? And the only way that you can truly do that is through waste reduction, right? You have to be waste reduction masters. You have to be myopic. You have to be laser focused. You have to be willing to provide and have that, right down to that nth detail to make sure that you're providing a safe, highly reliable care structure within your organization. That's where that value is coming into play. These hospitals and healthcare systems and clinicians who have successfully, navigated this value-based care system, they have taken and reinvested into streamlining their operations, right? Anytime that they have a waste reduction, anytime that they are reducing patient injury or harm, that they're finding leaner ways to operate, they are taking that money and reinvesting it internally into their own infrastructure rather than handing it off to a payer. And through that, they're able to build and expand and create a more robust infrastructure and footprint to be able to support a larger, healthier population size, right? Because it all ties into throughput and volume. And so, and CMS does, and I will say this, CMS does recognize that you're still going to have medically complex patients, right, that are going to be those high utilizers, but you need to have a large enough base of a healthier population to be able to sustain that, system, so you're keeping down your costs. And one of the other really essential elements for success that we found with these value-based care systems is that they're developing a sophisticated way to understand their cost structure. And they're starting to really be able to, they have to be masters of what it costs to deliver care. Because once you decide that and once you figure that out, that's where you can then start to see where your waste is, where your inefficiencies are so that you can maximize it. And now we know that not everyone can hit the ground running with, a sophisticated cost analysis module that sits within their EHR, within their billing software to be able to slice and dice all of their cost data for their patients. But I understand that we also have to kind of rip the Band-Aid off, and we have to start somewhere with understanding what is cost, how do we start to look at this strategically, and to understand how we are going to set ourselves up for success as we really transition into that value-based world. And so with that, I'm going to have Vance talk to us a little bit about cost measures.
Thank you. So understanding CMS cost measures. So I'm going to talk a little bit about the quality payment program. How many of you all are familiar with the quality payment program? Raise your hands. Okay, so I see several of you all raising your hands. The last presentation I did earlier this month, nobody raised their hand. So I'm glad to see you all do understand a little bit about it. So for those of you all that aren't familiar with it, it was stemmed from a macro legislation, I think back in 2017 is when the quality payment program started. And so I want to talk a little bit about that and how cost is involved with that. So first of all, it has to do with Medicare Part B billing. So if you bill for Medicare Part B, you could be required to participate in this program. There's some misconceptions that if you are an RHC, a rural health clinic, that you don't have to participate because you have separate types of billing. And for the most part, that may be true. However, that does not automatically exclude you. If you bill for ancillary services for Medicare Part B, those kind of things, you may still be required to participate. So keep that in mind. Also, a lot of people think, well, I'm part of an APM, an advanced APM or an APM. I don't have to participate. Well, actually, you are participating because that's part of one of the the tracks that you can participate in the quality payment program, it's through an APM. You're just kind of bound by the contract of your APM entity to kind of follow their guidelines and how you will participate. So talking about cost overall for that program, it's worth 30% total score for the program. So it's quite a bit, it's substantial. If you score perfectly on the other three categories, your promoting interoperability, your quality, and the improvement activities category, you still have to get 5 points out of 30 on your cost in order just to avoid penalty. Because to avoid penalty, you have to score at least 75 points out of 100. So cost is going to play a part, most likely, in your score. So it's really important to think about that. It's all based upon Medicare claims. There's nothing that you submit separately when you go to submit at the big end of the year, but it is all submitted through your claims throughout the year. Most of you all probably participate in the submission method of traditional MIPS. That's the most popular. Most people do that. With that submission method, there are 25 cost measures that you will be evaluated over and can maybe be attributed to. So there's 25. You have to meet case minimums for the measure in order to be attributed to have to participate for the cost. The MVPs, there's only a set number of MVP cost measures within that MVP track. So that's going to be a little bit different depending upon what MVP track that you may participate in. And then, of course, APMs, like I mentioned earlier, that's contractually based. Your shared risk savings is based upon that contract. It's baked in. The cost is baked in. So it'll be dependent upon that contract of how much of that cost plays a part of that. So what is the goal of cost in that performance category? Well, CMS wants to be able to have a national benchmark for those cost measures and for spending. So they've created this category so they can kind of analyze that and evaluate that to understand what each cost measure should be benchmarked at. And so it's produced through claims. That's how they will analyze that. And it's very important that your coders, your auditors, your practice managers, your clinicians and staff all understand that measure, what's attributed to that measure, what codes are built within that measure so they can code correctly in order to make sure you're performing as high as you can. So I mentioned benchmarking. They want to benchmark. The good thing about CMS is they do a real-time benchmarking. The downside to that is there's a 6-month lag until you find out what that is. So that begins after the performance period. They will analyze that for the first 6 months of the year. And then within the QPP feedback, you will get that real-time data around June, July is when that will be released. So you can see that what that national benchmark for each of those cost measures ended up being. And they will only be counted. You will only be counted on those measures if you meet those case minimums. And of course, how they calculate that score, each cost measure within the program is worth up to 10 points. So you can, and it's based upon your performance. So however you perform, it'll be out of 10 points, and they total those, how many measures that are attributed to you to get that raw score, divide it by the category weight, and that'll give you your final score. So how do you know if your clinician is going to be attributed to that cost measure? Well, it's measure specific. So each of those 25 measures have specific codes and windows and episodes that trigger that if they are attributed to that clinician. And then that's how they will determine that eligibility is through those triggering events and those codes. So that's why it's really important that the code is correctly, your documentation is accurate. And then, of course, they have to meet the case minimum. Each measure has its own case minimum. It's different for each one.
Alrighty, so we're going to talk a little bit about some of those specific measures. This is a really exciting portion of the presentation. I can see all those excited, smiling faces out there. But again, I think it's a good idea for us to have just a handle on what are we getting scored on? You know, what is that rubric that we're being evaluated and judged on? And so there's a couple different kinds of measures. There's global population-based measures. So those are going to be your total per capita cost and also your Medicare spending per beneficiary clinician. And then there's a Medicare spending per beneficiary clinician can kind of also fall into that episode-based cost bucket because it is looking at a specific episode, and we'll talk about that here. But then you have 23 specific episode-based cost measures that you could potentially be evaluated on by CMS. And those are going to be comprised of a couple different things. You're going to have procedural, you're going to have acute inpatient measures, and then you're also going to have, for 2023, they have 2 chronic conditions. Now, they have proposed adding some additional chronic condition measures, potentially for 2024, 2025. We'll know here maybe in a week or two what gets finalized when they drop the final rule here, likely the early part of November. So for these traditional cost measures, Vance just talked to you about how all of the different case minimums are going to be measure specific. And so you can see on this screen here that, you know, Medicare spending per beneficiary, you're going to have 35 episodes, right? 35 encounters. We'll talk to you a little bit more about what does that mean? What does that entail around that measure? And then CMS is also going to look at your Part B and Part A claims, that's spending across both sides of the spectrum for this particular measure. Total per capita cost is going to be around 20 patients, so it's a little bit less of a threshold. These two are the ones that we traditionally see both large healthcare systems and small independent practices these are you're more likely to get attributed one or both of these measures. These are the 2 original measures with the program. And so I think a lot of us maybe who've been a part of the QPP since its inception, we're used to seeing these 2 measures. It's the episode-based measures that we're just now getting feedback on. 2022 performance year was when a lot of the expanded number of measures has really started to hit. As I said, most practices aren't going to be measured and counted on at, all 25. Your very large healthcare systems that cover multi-specialty practices, they're going to be tipping that scale probably at least 15 to 20, maybe even close to that 25. Your smaller healthcare systems, they're going to be probably more in that like 10 to 15 range. Your smaller clinicians, you might not have any measures that trigger for you, or you might just have 1 or 2. And usually what we do see is that depending on the scope and care is going to be like your total per capita cost. So let's dive in, and I know that this information it's small print, and there's a couple things throughout here that might be smaller print, so it's more just for your reference. You're welcome to open up the slides. There's PDFs in the Whova app of our presentation if you'd like to dig into these a little bit more. But the main takeaways that I wanted to really talk about, because when I was practicing this and rehearsing this, and I was like, we just don't need to go down all these rabbit holes of talking about all these ins and outs of these measures, but I want you all to get some basic principles of what these are and why these are important, right? Why CMS is looking at these measures and are grading us and judging us essentially on our performance around these. And so the first measure, and again, these are the 2 population-based measures, Medicare spending per beneficiary clinician. And so this measure is looking at what they call an index admission around an inpatient stay. So that's the first thing I want you all to kind of put a little pin in. That is truly, in essence, what Medicare spending per beneficiary clinician looks like. It's looking at an episode of care around an inpatient stay. It's going to look at an episode window that's looking at 3 days before that patient gets admitted. And then it's going to look at a window of 30 days after. And that's going to be what happens both in that Part A, those MSDRG codes are what trigger that index admission. And then it's going to also look at your CPT codes and HCPCS codes that you drop that happen in that Part B world, before, during, and after that admission, to really evaluate the total cost of care around that inpatient stay. And so that is the next thing I want you to remember. So not only is this an inpatient measure that looks at both how much cost is, how much you're spending on the inpatient but outpatient arena. So it's looking at not only all of those stays that happen there, but it's looking at if they get discharged to a skilled nursing facility, if they are, they come back to the ED. ED utilization is a part of that. If a patient has an unplanned readmission as related to that index admission, guess what? That's going to extend that episode window another 30 days after they discharge, and you get all of those costs lumped into that same episode too, right? And so that's when our performance can get really out of control. One of the other things that I want you to keep in mind is that this measure applies to both specialty and primary care clinicians. So it crosses that line because it's looking at both parts A and part B. So you're going to find both types of clinicians that get attributed to this. It is a little bit of an easier one to hit, especially if you're a specialty clinician and you're providing services incident to an inpatient stay. And so one of the things that it does do, just to let you all know, is that if you have, say if you have a patient that's had an index admission and it's around an orthopedic issue, right? And that patient within 30 days just so happens to have a follow-up with their nephrologist, okay? They're not, that nephrologist care should not be attributed to that index admission because it's not related, right? So CMS is gonna look at those kind of outliers and they're gonna exclude those. So you might have some visits that fall in that 30-day window that are not gonna be a part of that measure. So that's just something to keep in mind. They do look at that and they try to match up the appropriate care that happens that's all related from that initial index admission. The next thing is total per capita cost. And what I want you to kind of take away from this one is this is a relationship-based measure with your primary care provider. And so this one is looking at those E&M codes that you're billing for primary care services, okay? And that's what triggers that initial, what they call a candidate event. So everything has a special name, right, for that thing that just launches that measure, whether it's an index admission or a candidate event, but it'll launch that candidate event and it's looking for an additional E&M code or a primary care service that falls within a certain window that then establishes a care relationship. And that is how they attribute primary patients to their primary care provider, is that relationship coding that happens. And so that's one thing I want you all to remember, is that it's a primary care relationship. Now, and it's based on those billing codes that are centering around wellness visits and those primary E&M lines. The next thing that this measure really does is looking at the overall costs of spending for Medicare patients within that performance year. And that's going to cross the lines with both parts A and B. It's going to look at their chronic conditions. It's going to look at their overall inpatient and outpatient spend. It's going to be looking at laboratory costs. It's going to be looking at that overall, how well as a primary care clinician are you managing the overall health of that particular patient? And that's what you're going to be scored on. One thing to also keep in mind with this particular measure is that it is a primary care-based measure, as I talked about, but we find that there can sometimes be specialists that are attributed. So that's something to keep on your radar. And sometimes it's appropriate for those specialists to be attributed simply because they are, for whatever disease state that they have, perhaps they're the best person to manage that patient's whole system of care at that point in time. But then there are also times that we find that we have specialty practices that get attributed this measure, and they're really not managing the totality of that patient's care. And we'll talk about that and what we do when we start to see that happen, because we know that that patient, if they're attributing, their nephrologist to manage their care, and that nephrologist is saying, well, I'm only handling this one condition. I'm not treating their asthma. I'm not treating their diabetes. We know that that patient then is probably not getting the best care management because they don't have that primary care relationship established. So like I said, we'll talk a little bit more about how that works when we get to that section. Now, again, this is probably really small for the folks here in the audience to be able to see, but I just wanted this up here just to kind of show you some of the different primary care services that really lead into when you're billing these the CPT and HCPCS codes. these are some of the things that start to establish that primary care relationship. So just something to keep in mind. Again, PDFs are on the Whova app. So next I want to talk with you a little bit about those episode-based cost measures. So again, those are 3 different types of of episode-based cost measures. So your acute inpatient cost measures, those are going to be things like simple pneumonia with hospitalization or the sepsis measure. And those are, again, going to look at parts A that are billed and those MSDRGs that are associated with that. Their procedural measures are going to be things like colonoscopies. They're going to be like knee arthroplasties. And those are, again, going to look at, your parts A and part B, and then your chronic conditions. So asthma and COPD, and then diabetes are the 2 that we have right now. And those, again, are going to look at the total spend for your patients with those chronic conditions across, both sides of the aisle. So that care coordination piece, right, from your inpatient, your outpatient, whether you are, providing all of those services in-house or that patient is seeking other care providers in the community, the reports and the data that you get is inclusive of the patient's experience and the patient's costs. It's not just costs associated with your particular tax ID. It's all of those costs that those patients are attributed to. Now, Vance also talked about some of the resources that CMS has and the measure code list. There's a lot of information to dive into. And I think it's always important for us to kind of direct you to resources, and definitely reach out to any of our quality improvement advisors. We are happy to kind of help you walk through understanding what kind of measures could trigger for us as an organization. Looking at your specialty, looking at the types of care that you provide is also a good indication of it. But CMS has measure code lists as a part of their measure information sheets that really go into the granular nuts and bolts details of how to try to figure out, okay, how can I anticipate what I'm going to see on my report next year? And so, we're definitely happy to help kind of walk you through where some of this kind of information is housed. And so you can see here just some of the different trigger codes, the MSDRGs, MSDRGs that drop for some of these different episodes of care. This is, again, not an exhaustive list because there's 23 measures and all sorts of codes that are attached, but just wanted to give you an example of some of the information out there that how you can start to kind of link back and say, okay, well, we do bill this CPT code, so this might be a measure we need to start looking at. And now with that, I want to hand it back over to Vance.
Thank you. Thank you. So it's a lot of information. Your minds are probably wanting to explode at this point, right? I'm sure you're not going to remember all of this. So it's too much to remember, but we just hope we give you some tidbits of information that you can pick up on and use as you prepare to try to drive some improvement and prepare for cost and value as you look at your organization.
There's totally a test at the end. Don't lie to them. There's a test. You all haven't seen it.
She made me do it, so it's Jessica's fault. So we've talked about where you can find this feedback. And so that is in the Quality Payment Program portal. So you would need to log into this. And if you log in, you can access that feedback report. So this just kind of walks you through the steps of how to do that. That little black box there shows you like a screenshot of what it looks like. You would scroll down till you get to the cost category, click on that link. And once you do that, you can find all kinds of wealth of information, really. So you can review those measures that you were scored on. You can look at beneficiary level data. So that's probably one of the most important aspects of this. You can click on that link for beneficiary level data, and it's going to give you everything about that specific patient and about the services around that cost measure. So really dive into that and do some detective work. That is the hard part about the cost category. There's no one report. There's no one piece of paper that's going to show you, hey, this is what you need to do to have lower cost. You're going to have to put that puzzle together and piece by piece and do some sleuthing on your own to try to determine what services are we utilizing the most, what types of patients, what patient population may be affecting our cost. Those are the kind of things that you want to kind of dive into. And you can also find out some items and services below the cost link. You can click on that and it's going to show you all of the items and services for the year that your organization has is using. So that is another wealth of information that you can utilize. Also, we've just put a little note on here too for 2022. If you did take that hardship, the extreme uncontrollable circumstance hardship, you cannot download beneficiary level data. That won't be available to you. So just know that if you go to try to do that, that's why. Just as a review. So as you're assessing that performance, it's really important to look at your historical cost performance feedback so you can compare years. How did you perform in the past couple of years compared to how you are currently performing? And you can kind of compare and see the differences to try to help you. Also, look at those case minimums. Are they increasing? Are they decreasing for each of those measures? And we're going to kind of look at that, what it looks like for the TPCC measure and the MSPB measure. Jessica's going to dive into that in just a second, what it looks like on that feedback report and kind of some items and criteria that you can find out from there. And also look at your current claims. How are you coding? What are you submitting codes for? Could they trigger certain cost measures? Those kind of things. Have any exclusions that may be available to you? So that'll kind of help you plan a little bit. And again, it's not that easy thing. You're going to have to be your own Pink Panther, so to speak, and figure this out and trying to put that puzzle together. I'm passing on to Jess.
All righty. It's some sleuthing time, you all. I know you guys are excited. So Medicare spending per beneficiary. Okay. So let's talk about this a little bit. I did tell you there was going to be a quiz and a test, right? So who paid attention to my rambling a couple minutes ago and can tell me, what does MSPBC measure? What does that examine? What is that looking at? What care setting? Inpatient, ding, ding, ding. Who said that? 5 gold stars for you. All righty. Yeah, so it's looking at that inpatient interaction, and it's going to also look at what happens in that Part B setting and outside. And I know this is super teeny, 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 tiny font. But again, these PDFs are in the Whova app. But what's up on here, right? So we have, well, and I will tell you, both of these files have been de-identified of any patient data. When you go into the QPP system, you're actually going to have information around each and every patient. This is a patient list, and it's going to have like their Medicare number, which, by the way, there are still Medicare numbers out there that link to Social Security numbers. So just be mindful of that when you look at these reports. It's going to have their date of birth. It's going to have their inpatient discharge date, and some other different factors. It could have the physician's NPI that it's attributed to for this particular measure. So you can actually trace it back and forensically, as Vance said, Pink Panther it, to be able to find out a little bit about what's going on with this patient's care and their journey and their story of why they ended up in your bucket. And so the things that I want you all to kind of take a look at through here, because this is going to have a wealth of information. This is one of my, putting my little QI nerd hat on, this is one of my favorite reports to dig into and look at. And, you know, my team is probably in the back rolling their eyes. We've got a training coming up on this here in a few months. So this is a little preview. But what this is looking at, again, this is looking at all the different areas and buckets of where that patient could have received care related to that 3 days before and 30 days after. And it's going to break down and itemize those costs, those expenditures, that spend for that particular place of care setting. One of the other things that I want to call your attention to is on this report, again, you can't see it on this first column, but it's HCC percentile ranking. And Vance, I believe, talked about it a little bit. HCC scores are becoming more and more pivotal in being able to capture that information and documentation for your patients, not only in the cost front, but it also impacts your quality score performance, okay? It factors into your complex patient bonus. QPP is a numbers game. You have to be able to maximize your numbers to be able to hit your target. And so finding these strategies that cross-cut different types of measures to help maximize your performance are essential. And so I want to just take a couple minutes here and just talk with you very briefly about HCC scores and why they are important. So your HCC score is going to be it's going to be those patient characteristics, those social drivers. It's going to be the prior health conditions from a previous year that are still ongoing. And it's found in the documentation on those Medicare claims. So capturing the documentation, attaching the appropriate codes is crucial for your practices, for your clinicians, for your healthcare system. CMS is not going to know that if you've had, and Robin Colonel, I don't see her in here, she always uses this example and I absolutely love it, is that if you have your leg amputated and it's documented in 2021, but in 2022, they don't document that you had your leg amputated, CMS looks at it like you've had a miraculous healing and your leg has grown back. And it has not. So you have to capture your documentation every single year for any ongoing persistent disease conditions, states, any special social factors, anything like that, because CMS looks at that, they identify that, and they place a ranking, and then they also apply what they call a scaling factor. So if you have more complex care factors related to you, you're going to get a higher score, right? And so it's from 1 to 100 points is your ranking. And so say if you are at 83, that's your ranking. That means that 83% of the national population is less medically complex than you are, right? And so that's, again, something for us to consider is making sure we're capturing this information. It's incredibly important, and I'll tell you why. So we're going to start talking about strategies, right? What is it to talk about a measure if we can't, give you at least a jumping off point on where to start to dig into these reports and to understand this information a little bit better? So when you pull this down from the QPP portal, and even if you don't have 22 data, because maybe you didn't submit for cost or you took an EUC for it, CMS did release 2021 data. And it's not compared against a benchmark because they suppressed 2021 from scoring, but they did have some files. So it's going to be a little old. It's going to be influenced by COVID. We know this, but it's data that we have. And so, you can always pull that or some of your historical reports to start looking at this. But the first thing I want you to do, whenever you pull this report, you can put it into a pivot table, you can drop some filters on it, whatever floats your boat and makes you happy and brings you joy. But what I want you to do is I want you to be able to tell me what is your average and what is your median HCC score. You have to know where you're at, right? Before you can decide where you want to go. Regardless of what benchmarks are for other organizations, you have to look internally first, right? And then I want you to figure out what your average and your median episode cost is, okay? And that's going to be listed right up here, right next to your HCC percentile ranking. That's that next category over. Those are two different numbers that I want you to kind of keep, and that's going to be where you're going to kind of judge and gauge some of your performance. The next thing I want you to do is I want you to sort that list, and I want you to group by providers. And I want you to start to look to see if you can identify trends in your providers. Do you have a disproportionate amount of providers with higher HCC patients, meaning that you have more providers front-loaded with medically complex patients, and you have other providers who are providing the same kind of care, and they are not being attributed these? So what can you do and what can you look at operationally, right, for your patient empanelment, for assignments and that type of thing? How can you help distribute that more evenly, or how can you direct more resources to those clinicians who are treating the sickest of the sick in your hospital or your healthcare system? Then the next thing I want you to do is, and another way to look at it, is I want you to take and I want you to look at sort your list by your highest HCC scores and then your highest cost. And you want to look at those folks who are, at least a score of 75 or higher. Those are going to be by far your more medically complex, right? And you're going to find, truthfully, even if you just look at your first 10 patients on that list, you're going to be able to find a lot of trends. You're going to be able to maybe make some solid assumptions around the care, but you're going to do some chart reviews. You're going to look at that patient's experience. You're going to pull that and you're going to see what is attributing to this patient's high cost and their medical complexity. Does this make sense for our organization that's happening? Are we using transitional care management? Some of those techniques that Vance talked about. You know, how are we doing that? How are we transitioning those patients from discharging to a skilled nursing facility to their outpatients? Are we seeing them within 7 days after discharge? Or are they coming back through our ED? What is our readmission rate? What is our unplanned readmission rate? Starting to look at those and compare and to see where your trends lie. Then the final thing that I want you all to do is I want you to look at your HCC scores that are below the 50th percentile. I want you to pick those out. And then I want you to look and you want you to sort that list by those people who have a low HCC score, so less than 50, but they have higher than your calculated average or mean or median cost, right? So you can pick either one. But I want you to find those who are your high utilizers of services, but they are not chronically medically complex patients, okay? And then once you do that, this is where you can actually tell, one, if your HCC scoring is being done correctly. Because if you go through and you pull a patient and you see, well, they're not listed as being medically complex, but you know what? They've had cancer, they have diabetes, they've had a heart attack, they have COPD, they have all of these things, but they're ranked at a 30. They should not be at a 30. And what that is telling you more than likely is that there's something going on with being able to capture your drivers, being able to capture that patient's care. And so that's where then you can start to make some targeted interventions to address that population, to address how you're documenting to get those HCC scores up. Because remember, your CMS is not going to penalize you for treating complex patients. They're not going to. They're going to actually give you favorable scoring if you're taking on and assuming that risk, right? It's just how you're managing those complex patients is really what they're trying to evaluate here. And so think about those folks and, you know, why are they so high cost if they're not that medically complex? What are things that you can do to change in your care delivery system to help address those needs? You know, is it a matter of their high ED utilizers and you need to expand your telehealth services? You need to expand and have greater access to urgent care, things like that you can then work on and make a difference and a change in. The other one I want to talk to you about is total per capita cost. And again, another pop quiz. What does total per capita cost entail? What's that looking at? What relationship? Primary care? Ding, ding, ding. Okay, good job. So again, this is that primary care relationship. All of the things that I talked about with HCC scoring, I'm not going to regurgitate. This applies here too. HCC scoring is where you're going to get the most bang for your buck doing that work, okay? One thing I do want to talk to you about again is you're going to still pull those same scores. You're going to pull your median HCC and you're going to pull what's called your total scaled cost. And this is somewhere in like the first quarter of this spreadsheet. And that's going to be looking at all your standardized scaled costs across Part A and B. Okay, but you're going to want to find that average. And you're going to do that same logic that we talked about with Medicare spending per beneficiary. You're going to ask those different questions around why are my highest acuity patients and my highest cost utilizers, what's going on with them? One of the really interesting things that I love about this feedback is that it actually breaks down if your patients have more than one or more of these chronic diseases. It's going to look at diabetes, CAD, COPD, and heart failure. And so you can look and see, do we have patients who are our high cost utilizers that have one of these chronic conditions or more than one? And then start looking at what is our CCM looking like within our organization? What services are we providing to help manage these chronic conditions? And you're going to, as you start to work on that, you're going to be able to start being able to see some improvements in these areas as well. All right.
Oh. Grab the wrong thing. So as you're planning and trying to put some improvement processes into place, what do you need to think about? So first of all, we kind of suggest that you look at your different measures and what could be applicable to you. And to do that, you want to ask yourself, do you admit patients in the hospital? Do you provide primary care services and E&M billing? And also, do you perform or bill procedures or episode-based related codes. So if you're doing any of those things, that will help apply to see which types of measures might be applicable to your practice. And once you do that and you have a list of those potential measures, cost measures, then you want to look at those different measure information sheets and learn about that. What is entailed? What are the details? What's the numerator? What's the denominator? Those kind of things. Are there exclusions? Really understand the specifics of that will really help you perform well with that. Learn the different attribution methodology for those as well. So you know if your clinician could be attributed to your group. Also, like we've said it several times, analyze your past cost performance. How are you doing from the past few years until currently, and kind of analyze that to get some information. And coding. Document. That CDI is so important that you're documenting accurately from your clinicians, providers, staff. That is going to really help with those HCC codes, et cetera. And then once you kind of have that idea, that's when you can start putting those quality improvement processes into place. Maybe do a sprint, a PDSA, whatever your organization uses in order to try to improve upon that. So some suggestions, some top tips and tricks that we think, of course, review your feedback reports and those items and services. Learn all the details that you can so you can do that detective work. Look at those high acuity patients. Understand those patients with those chronic diseases. That 1%, remember at the very beginning of when I started, 1% of the patients contribute to almost a quarter of the cost. So if you're just looking at those patients that you care manage probably, that care management population, look at those conditions and how you can help that. Look at that trigger code list that Jessica mentioned a little bit earlier so you know what's triggering those measures. And then, of course, those patients with comorbidities and those chronic diseases. And then if you're not getting evaluated and scored on costs, is there anything that you can do? Well, CMS, when they are looking at implementing new measures, they do some field testing, and that will allow for you to have some practice, so to speak, without being penalized and get feedback. So if there's some new measures coming out, you can apply to be part of that field testing so you can get that cost performance feedback to you in the case that you're not getting much cost feedback, and that will be very helpful.
And then just a couple quick notes. In your folders on, I believe, the right side, you're going to see some handouts from our quality and value team. We have a cost overview information sheet. These are some of our client materials who work with us for our fee-for-service and QPP service lines. We also have just an overview of cost measure attribution, because I know you want some lovely bedtime reading tonight. And then we're also have some information on social drivers and HCC scoring that's found within your sheets as well. Those are also going to be on the Whova app as PDFs to be able to download. If you all have any questions for us, please feel free to grab Vance and I at some point. Well, don't grab, but get our attention, and we will be more than happy to talk with you all, answer your questions as best to our ability, or get you in contact with the information that you need around this. So we really want to thank you so much for your patience and time and attention to this topic today. So thank you. All right, and here's for the fun stuff. We've got some awards from the quality and value team that we would like to recognize some of our practices and systems that we work with throughout the year related to some of our work. This first award right here is our Healthcare Innovation Award for our CDC and Kentucky Department for Public Health, our Asthma 1902 grant. This grant in particular is very near and dear to my heart as someone with asthma and with a child who has childhood asthma. This is something that I am just thrilled to be a part of and to see all of the innovation and wonderful things that are coming out of this. This partnership is actually with the Kentucky REC and the Kentucky Asthma Management Program, or CAMP, within the Kentucky Department for Public Health. CAMP received this grant through CDC funding to promote asthma awareness, improving patient outcomes, and to engage clinicians in adopting and expanding asthma self-management education services within their communities. This organization that I would like to recognize has done a fantastic job over the last year. They have assembled a multidisciplinary team comprised of pulmonology administration, pharmacy, ASME certified educators, health informatics, data analysts, and marketing resources to lead their quality improvement project across their organization. They've been starting out with doing piloted focus sprints and PDSA work within their communities to ultimately be able to scale and spread these innovations across their entire health system. They've worked to expand and grow their ASME services. They've launched marketing campaigns. They've held fairs. They've done education and school systems with other community members as well, speaking, I believe, at Kiwanis and all sorts of different things, right? To get the word out about asthma education within this particular region. They've also done a lot of work within one of the local school systems, working and partnering with the Kentucky Stock Albuterol program. They partnered with a local school-based clinic to provide clinic staff training and rescue inhalers in these school-based clinics. They've also been partnering with athletic trainers within this region to be able to have toolkits and tool bags of asthma supplies in case there is somebody who does need a rescue inhaler. So this is a wonderful program. I'm so proud to work with King's Daughters Medical Center. So if Jen and Sarah, if you want to come up and get your award. Thank you all so much. Thank you. And then if you do want to take any pictures over here into the patio area afterward with your whole team, you are welcome to do that. Megan will get you taken care of. She really wants to take pictures, so please. All righty, and just real quickly, our next award, we are recognizing a practice. Unfortunately, they are not able to be here today. They're joining us virtually. Oh, I didn't do the fancy little graphics. I apologize. Sorry. Thank you, Vance. They are unable to be here in person, but I believe they are joining us here virtually, is a single provider dermatology clinic in Western Kentucky that they've been submitting for the quality payment program and working with us since 2017. They have, and what makes them, we think, a superstar for the quality payment program is that they have been utilizing, they don't have an EHR. They have been utilizing a registry this entire time, trying to optimize their systems to be able to really successfully perform in the quality payment program. And in fact, they have received a perfect score each and every year, even through COVID, utilizing a registry. And we really want to commend them on the hard work, their diligence that they have taken to ensure that every encounter is getting the credit due and is being entered in appropriately into that registry so that it can be counted and awarded. And so the Kentucky REC would like to recognize and award the J. David Outland Clinic with the QPP MIPS Innovation Award for their steadfast work in quality improvement and the QPP MIPS track and their overwhelming commitment to community and patients. I believe their advisor, Robin Colonel, is going to accept the award on their behalf.
So our next award is our PCMH award, the Heart of the Patient Award, excellent dedication to patient-centric care and the patient-centered medical home. So this practice back in 2017, I believe, began their PCMH journey. And they started with us. We helped, one of our advisors helped them get the PCMH recognition several years ago, and they worked really hard. And this past spring, they were able to get distinction in mental health, the behavioral health distinction with NCQA as well. They also had to do their annual reporting. And then at the very same time, they got audited with NCQA and they passed with flying colors. So they had to go through and endure a lot. And then on top of that, they were also involved in the Eastern flooding with their patients. A lot of their staff was involved with that too, but they still continue to provide that care to their community. And so we want to award this to Little Flower Clinic. So Ellen, if you and your team will come up. And I want to ask their advisor, Vicki Harden. She was instrumental in helping this clinic get their recognition and distinction this year. So congratulations to you guys.
We're very blessed for the hands-on but we can't do it a lot. It takes an army, right? To run to the community. So it's everything that works.
Can we hear me now? Good. Good morning. I'm Lacey Shumway. I'm the Coverdale Stroke Program Manager, and I would like to talk just briefly about Cumberland Family Medical Center, who is receiving our Exemplary Coverdale Stroke Grant Award. Cumberland Family Medical has been instrumental in helping to grow our work with the Coverdale Grant. Their excitement and dedication to utilizing the Care Collaborative program to help their patients has led to numerous stories of success within their patient population by improving the self-management of their own blood pressure and encouraging lifestyle modifications. Beyond the success they've had with their patients, they have also provided best practices for the implementation and monitoring of the Care Collaborative program as it has spread to other grant participants. Their stewardship in implementing the Care Collaborative and cooperation to share their barriers as well as their successes has made working with this practice extremely beneficial and enjoyable. We cannot thank them enough for their hard work on the Coverdale Stroke Program Grant. So if Megan McMillan and Chantella Burton would come forward to receive their award.
All right. Well, it's 10 a.m. We are going to break for about 15 minutes. Just to let everyone know, the restrooms are directly back there, and we do have restrooms if you go down the steps. There's restrooms in the same place on the first floor. Also, one key, if you decide to use the elevator and you're going down, you have to hold the down button in to go down until you're at the bottom, and the same thing coming up. So don't get stuck. Just wanted to let everyone know that because I got in there yesterday and couldn't go down. So also, I know the wording is small on some of the slides. So if you have downloaded the Whova app, the PDFs are out there and you can see those on your phone as well or your mobile device. So appreciate it. And we will start back again in 15 minutes at 10:15.